We are on chapter 9. This is our third to last chapter. It's almost the end of the summer semester. So pat yourself on the back. You are almost there. Hang in there. Keep on doing your practice problems. Keep reviewing. Make your note cards. Just keep on hanging there. Keep on studying. You're almost to the end. And then in August, about mid-August, we're going to start EKG 2. And this is when you're going to be able to take everything that you've learned from EKG 1 and put it into practice in EKG 2. And then you'll be ready to start looking for a job or to just interpret rhythms or get promoted at your job, whatever reason you are taking this class for. You're just one step closer. So, chapter 7 and chapter 8. Chapter 7, we had talked about your sinus rhythms. In chapter 8, we had talked about rhythms that come from your atria. So chapter 9, we're going to talk about rhythms that are going to come from your AV junction. Remember, AV stands for atrioventricular junction, meaning that impulse, if an impulse comes from my AV junction, it is going to go either up to my atrium or down to my ventricles. If you remember back in chapter 3, I think it was, we talked about your beats per minute, your heart rate, and we talked about how the conduction system, it starts with the sinus node, it then goes to the AV node, and then it goes to your ventricles. And then you learned that we can have rhythms that come from the sinus node, rhythms that come from the atria, and now we're going to learn rhythms that come from your AV junction. But if you remember back to chapter 3, I could be wrong on the chapter, but if you remember, if we have rhythms or impulses that are coming from the sinus node, my heart rate should be 60 to 100 beats per minute. And if they're coming from my AV node, then they're going to be 40 to 60 beats per minute. And if they're coming from my ventricles, they're going to be 20 to 40 beats per minute. So just keep that in mind. So if we have an impulse that is coming from the AV node, it could be between 40 and 60 beats per minute. But also keep in mind that if that impulse is coming from my AV junction, that means my atria rhythms impulses have failed and my sinus rhythm impulse has failed. But also they could just be at a slower rate or a faster rate. So we could still have impulses coming from those nodes. It just depends on how we look at that rhythm when we interpret it. So let's go ahead and get started with chapter 9. It's a little shorter than the others. You should probably know by now the basics, which is you're going to ask yourself those questions, how to interpret that rhythm, and all you're doing is learning these new rhythms and their new rules. If you are not quite yet familiar with the rhythms from chapter 8 and chapter 7 and their rules, get those note cards, write the name of the rhythm on one side and write the rules on the back. And don't forget to go ahead and start memorizing what causes those rhythms, how do we treat it, and the effects of the heart, because that's all going to come back at you in EKG 2. So go ahead and get that studying out the way to where when we get into EKG 2, you're not having to go backwards and relearn everything in EKG 1. Okay, so introduction, your junctional rhythms, again, we're talking about the AV junction. They're going to arise from the AV junction. Impulses originate around the AV node, travel antegrade to the ventricles. So let's think about it. Where are your ventricles? Are they your top two chambers or are they your bottom two chambers? They are your bottom two chambers. So if I am going antegrade, I am going forward to my bottom chambers. So if an impulse originates from the AV node and travels antegrade, which means forward, to the ventricles, or it can travel retrograde towards the atria. So think about it. My atria are the top two chambers, right? So if my impulse, my AV node is in between, my atrioventricular node is in between my atrium and my ventricles, and I have an impulse that is going towards my atria, it's going back up. It's going backwards. Retro. Think about your music. Retro. So if I am going retrograde, I'm going backwards. And if I am going antegrade, I am going forwards towards my ventricles, retrograde backwards towards my atria. This is why this node is called the atrioventricular node, because it's going to send an impulse backwards and forwards to my atria chambers and to my ventricle chambers. So that AV junction area can then be divided into regions. These regions are high, mid, and low. Whichever region initiates the impulse will determine the location of the P wave. So let's just refresh real quick. In chapter 7, we learned about the sinus rhythms, and we learned that all my P waves in the sinus rhythm should be upright, they should be married, and they should be matching. And then in chapter 8, your atria rhythms, we learned that our P waves, they're going to be upright and they're going to be married, but some of them are not going to match others, meaning they're coming from different foci, irritable foci. So our clues into determining what rhythm we're looking at is if my P waves are upright and matching, I'm more than likely coming from a sinus rhythm, sinus node. But if my P waves are not matching and it looks like they're all different kinds, they're coming from different impulses, I could be coming from my atria. And now we just learned that for my AV junction, whichever region initiates the impulse will determine the location of that P wave. So depending on where my P wave is at on the rhythm will tell me what region of the AV node it is coming from, high, mid, or low. So your P waves are very important. When we start asking ourselves the questions and we start looking at these rhythms, the first thing we want to point out and find is my spikes, which indicate my ventricles, my QRSs. And then we want to also look at the shapes of our P waves, because that's going to give us a hint on telling us whether that rhythm is coming from sinus, atria, or your AV node. So if the impulse originates high in the AV junction, it will arrive at the atria first and write an inverted P wave preceding the QRS. A lot of terminology here. So it will arrive at the atria first. Atria is your top chambers. And it's going to write inverted, meaning upside down, negative P wave. So our P waves, they're supposed to be positive, right? And upright. In this case, if it's coming from the high AV junction, it is going to write a negative P wave preceding the QRS. Preceding means before. So if I have a negative P wave before the QRS, my impulse is coming from the high AV junction. And the PR interval should be less than 0.12 seconds. Now, if you remember your rules, we are comparing all rhythms to the sinus rhythm, the normal rhythm of the heart, the originating rhythm of the heart. And we're told that our rules for the PR interval needs to be between 0.12 and 0.20 seconds. But if I am coming from the high AV junction, my PR interval should be less than 0.12. So I know I'm putting a lot of emphasis on this, but I just want you to hear me saying it in your head to to point out these little bitty rules, these hints. It's very important for you to understand how to interpret the rhythms, but also you got to know all the rules of the sinus, the rule of the atria, and the rules of your AV. And we know that your AV is going to have 3 regions: high, mid, and low. And how do we tell if it's a high region that impulse is coming from? P waves will be negative before the QRS. My PR interval will be less than 0.12 seconds. What about mid-junctional impulses? We're not going to be able to see these P waves. Now keep in mind, chapter 8, if we did not see a P wave, we assumed it was buried in that T wave. And you can kind of look at the T wave and see that P wave buried in there. But if we do not see a P wave in this case, it could be coming from the mid-junctional AV node. And if it is coming from the lower AV junction, that P wave is still going to be inverted, but guess what? It's going to follow the QRS. So we know that in normal rhythm, we should have P wave, then your QRS, then your T wave. But if that impulse is coming from the lower AV junction, the P wave will be negative, and it will be following after the QRS. So this is really important information here. I would make you a slide and maybe just label it AV junction, and then on AV junction, just put all this information on there so that you constantly see it and you constantly repeat it. When you're studying, if you are not talking out loud to study and you're not grasping the information, the more you talk out loud, the more it sinks in to your head, the more comfortable you come with talking about these rhythms. And sometimes it just takes talking it out loud to understand it. So if you've been reading your book, you're making these note cards, and you're watching these videos, and you're still having a hard time understanding the material, start talking it out to yourself, and maybe that will be just what you need to help you better understand the material. So here goes our image. So I'm going to use green. So we know that right here, it's going to be my sinus node. And we know that my sinus node is going to take interatrial tracts or internodal tracts to get to my AV junction. I want you to think of your AV junction, which is right here. I want you to think of a relay race. Your AV junction, you have to have multiple people in a relay, right? You got somebody holding a flag and somebody holding the baton or whatever it is that they're passing. Let's say a baton. And you have somebody at location A who is running to location B where somebody else is. So location A person, once they get to location B, they give the baton to location B, and that person starts running to location C. This is your AV node. This is location B. They're waiting for that impulse to come from the sinus node location A. If that impulse does not get there on time, the AV node, or the foci around the AV node, is going to become irritable. They're getting anxious because they're waiting for that baton to be passed by. Everybody else is getting their baton but them. They're irritable. Eventually, that irritable foci is going to jump the gun. They're going to dart without having that baton. That could be that premature beat. Or the sinus node impulse from location A is going so slow that that premature beat is sent from the AV irritable foci, and then the sinus node still gets through, and that sinus node impulse now becomes an escape beat. So this is where you get your premature beats and your escape beats, if that helps you better understand them. So in my AV junction, I'm going to have 3 levels. We're going to have high, mid-junctional, and low junctional. And for my high junctional, my P wave is going to be inverted before my QRS. For my mid-junction, I'm not going to have a P wave. And for my lower junction, my P wave is going to be inverted behind the QRS. That tells us where that impulse is coming from. So here, if you look in your images over here, notice that my high impulse, my P wave is negative before my QRS. My mid, there is no P wave. And my low, my P wave became behind the QRS. Now remember, for my high impulse from my AV junction, that PR interval is going to be less than 0.12 seconds. So, the word on junctional rhythms. It is seen less often than your sinus or atrial rhythms. So when you're looking at these rhythms and you're trying to determine is it sinus, atrial, AV, or ventricles, we know that my AV is seen less often. The majority of the time, my rhythms are going to be sinus or atrial. They are easier to identify an AV rhythm. Why? Because of your P waves. P waves negative, where can it come from? AV junction. P wave becomes behind that QRS and is negative, AV junction. All right, so now that's it. That's chapter 9. That's the new information. So now it's just learning the rhythms that go with chapter 9. And if you haven't figured it out, they pretty much repeat themselves. They're very similar to the rhythms before from the sinus and the atrium. So a premature beat that originates in the AV junction before the next sinus beat is due. A premature beat is called a PJC. This is caused by an irritable tissue or an irritable foci in the AV junction firing, that's an impulse, and usurping the sinus node. I'm not sure if I told y'all that, but usurping, I think of hiccups. Think of your breathing pattern. When you have the hiccups, you have little breaths in between each hiccups right there coming before you can get a full breath in. That's usurping. So if I have a premature junctional complex, that irritable foci is firing and usurping the sinus node, meaning it's coming before that sinus beat. That sinus beat might have took too long. My irritable tissue got tired of waiting for the baton and it took off without the baton. It usurped it. It hiccuped. It fired off before the sinus node. So my sinus node then becomes that escape beat. So what rate can a PJC occur at? Any rate. What's its regularity? Regular but interrupted by a premature beat. P waves, they're going to be inverted or absent. And my PR interval will be less than 0.12 seconds if that P wave comes before the QRS. If it comes after the QRS, you cannot measure your PR interval if you were thinking that. Your PJC, the QRS, is going to be less than 0.12 seconds, which again, when we compare that to sinus rhythm, that is considered normal. What can cause us to have a PJC? Stimulants, hypoxia, heart disease, and nicotine. What are some adverse effects with a PJC? There are usually none. What is the treatment? Treat the cause. What is causing it? If it's nicotine, then what we're going to tell that patient, no more nicotine. So this is what a PJC looks like. So remember your questions, and the questions go, do you have QRSs? What is your heart rate? Do you have P waves? Are they matching or married, etc.? Your PR interval, your QRS interval, and so forth. And so if you look just by quickly glancing at this rhythm here, and you just learn that if we have a negative P wave, it's more than likely coming from the AV junction, we can easily point out that here we have a negative P wave. Look at this one right here towards the end. That one is perfectly negative. Negative. This one's kind of hard because you kind of want to say this is the P wave, but then it becomes negative. So I'm going to ignore that one because it's very hard to see. And I'm going to show you. I'm going to erase it so that you can see why. But here I can clearly see we're negative. And here it's probably easier to tell that we're negative. So if you notice, we have a negative P wave. And then over here on that very last rhythm, I don't really have a P wave at all. I can't tell where it begins or where it ends. I know it's supposed to be right there. And I could assume that it is right here, buried within my T wave. So if all of my P waves on this strip looked like this last one where I have the arrow, then it might fool me and make me think that this rhythm is coming from the atria. But I have all of these negative P waves, and if I have a negative P wave, that tells me that that rhythm is coming from the AV junction. Now, if that P wave is negative before the QRS, I am coming from a high AV impulse. But if that P wave was after that QRS, I would be coming from a low AV junction impulse. So the next rhythm, so that's your PJC, right? Premature junctional complex. The next one is going to be a junctional bradycardia. So notice, if we're talking about rhythms from the AV, it's going to be referred to or related to as junctional, okay? AV junction. Bradycardia, we already know what that means. That's going to be a low heart rate. If I'm a bradycardia coming from the sinus node, my heart rate is going to be less than 60 beats per minute. If it's coming from the atria, a bradycardia is going to be less than 100 beats per minute. But if it's coming from my junctional, my heart rate is going to be less than 40 beats per minute. Because what is my beats per minute coming from the AV node? 40 to 60 beats per minute. So if I'm a bradycardia coming from the AV node, the rules of the AV node is it's 40 to 60 beats per minute. So my bradycardia is going to be a lower heart rate, less than 40 beats per minute. Look at this, regularity. So my PJC was going to be regular but interrupted by that premature beat. But my junctional bradycardia is going to be regular. P waves are going to be inverted or hidden, so we might not see those P waves. PR intervals less than 0.12, only if it comes before the QRS. QRS is still going to stay with my rules less than 0.12. What can cause us to have a junctional bradycardia? Vagostimulation, hypoxia, sinus node ischemia, or heart disease. Sinus node ischemia, when you see ischemia, that is one of your three I's, your injury, ischemia, injury, and infarction, your myocardial infarction. These are the three signs of a heart attack. And that is the very first sign that this patient could be going into having a heart attack. What are some adverse effects of a junctional bradycardia? If you don't know the answer, your answer is always going to be decreased cardiac output. But if I have a PJC, there is no effect on the heart, and very few other rhythms do not have effects on the heart. So if this is hard for you to memorize, I would make you a note card and write on it what rhythms affect the heart or decreases cardiac output and what rhythms do not. How do we treat a bradycardia? We can give them atropine. They could get a pacemaker to make their heart beat a little bit faster. Oxygen. We're going to hold any bradycardia inducing medications. Why? Because a bradycardia is lowering the heart rate. So if we're giving them a bradycardia inducing medication, meaning we're trying to induce the bradycardia. Think about pregnancy. a woman is induced into labor to have that baby. So if we're going to give them bradycardia inducing medications, we're causing their heart to beat slow. So if they're already having a slow heartbeat, which is a junctional bradycardia, we do not want to continue to give them any medications that could induce a bradycardia. We want to consider epinephrine or dopamine infusion to increase the heart rate. So this is what a junctional bradycardia looks like. So if you notice your P wave, we could kind of assume in the middle that it's coming after your QRS here. It's following it, right? If you see this little dip here, we could assume that there. But if you look over here, we cannot pinpoint the P wave. And then if you look over here, this is where our rule comes. You can see it buried in my QRS. See it here? Okay, that's your junctional bradycardia. And if, just for fun, if we wanted to figure out what the heart rate was, we can tell that this is 30 beats per minute. Okay, the next rhythm is called your junctional rhythm. So the last time we had just the name of the node in front of the rhythm was your sinus rhythm. This one is going to be known as your junctional rhythm, and it's going to originate in the AV node, and it is usually an escape rhythm. The rate for a junctional rhythm, this is going to be your normal junctional rate, right? 40 to 60. So your rate for a sinus rhythm, 60 to 100. Your rate for a junctional rhythm, 40 to 60. It's going to be regular, but my P waves are going to be inverted or hidden inside the QRS. Now remember your atrium. If it's coming there, your P waves can be hidden in the T wave. So how important is it for you to find your P waves? Very important, because that's going to indicate or signal where that impulse is coming from. Your PR interval is going to be less than 0.12 seconds if the P wave precedes the QRS. QRS will remain less than 0.12 seconds. What can cause a junctional rhythm? Vagal stimulation, hypoxia, sinus node ischemia, heart disease. Pretty much the same as your bradycardia, right? What are some adverse effects? Decreased cardiac output. What is the treatment? Atropine, oxygen, hold bradycardia-inducing medications. Consider a pacemaker. Consider epinephrine or dopamine. This is very similar to your bradycardia. Except for my rate is going to be between 40 and 60 beats per minute. So let's see. 10, 20, 30, 40, 50, 60. Your book is actually correct. There's so many mistakes that I found in the book, and it's pretty exciting to see that they gave us a good example. 9 times out of 10, we get a good example. So, junctional rhythm. My hit is my P waves. Do you see P waves here? Very hard to see. We can assume that they're hitting in your QRS. So again, I'm going to use green. If I look over here, you see how this QRS kind of looks funny over here? I can assume that my P wave is in my QRS. And again, if it's a junctional rhythm, that P wave is an escape impulse, an escape beat. And also notice this rhythm here, especially right here, if you were only looking at this one section, you might assume that this was a atrial fibrillation, right? It's wiggly and vibrating. But if you look at the rest of these, intercessions between beats, it's not as wiggly as that one. Okay, so then in your second QRS, if you notice, my P wave, it doesn't look like it's hidden here, like the first QRS, but maybe it's here. And same thing, look at here. Now we might mistaken that this is a premature junctional complex, because we might think that that P wave is coming behind the QRS here. And the rest of those look very similar to this one. So just keep in mind, it is very important to go through your questions. Do you have QRSs? Do you have P waves? Are they upright, matching, and married? Are your intervals for PR and QRS within limits? What is your rate? And then interpret your rhythm. The next one is called your accelerated junctional rhythm. So we should all know that accelerated means speed up the process, right? Going super fast than it would normally go. So far we had a PJC, a junctional bradycardia, a junctional rhythm, and now we're looking at an accelerated junctional rhythm. Remember that my junctional rhythms are only 40 to 60 beats per minute. So if it's a junctional bradycardia, my rate is going to be less than 40 beats per minute. But if it's a junctional rhythm, my rate is going to be between 40 to 60 beats per minute. So if I have an accelerated junctional rhythm, we can assume my rate is going to be more than 60, and in this case, 60 to 100. It's going to be regular, P waves inverted and hidden, PR less than 0.12 if before the QRS, and QRS as always less than 0.12. What can cause an accelerated junctional rhythm? Look at that last one, caffeine. All you energy drinker people, don't drink energy drinks, because it's going to give you an accelerated rhythm. And we know that if we have an increased heart rate, what could that lead us into? Having a MI. And we want to keep our hearts healthy, not pump it up with caffeine. Anyway. What can cause accelerated heart disease? Stimulants and caffeine. Adverse effects, usually none. Treatment, usually none. Remove the cause. So if my heart's going super fast, I want to stop drinking those energy drinks. Do not keep drinking them. Here goes your accelerated junctional rhythm. Notice it's very hard to predict where that P wave is here. If you look at the middle one, it almost looks like maybe that could be a P wave because it looks different than the rest. We know that it says a faster rate, 10, 20, 30, 40, 50, 60, 70, and an accelerated junctional, it has to be between 60 and 100. We know it's junctional because you do not see a P wave. And also, I want to point out, this slide is perfect to point out before we get to chapter 10, your QRSs, and I always do this and it might seem funny on video, but your QRSs, they are narrow. Let's see if I can angle it. They're narrow. I'm sorry, I'm picking my fingernails. They're narrow. Where's my hand? They're narrow. But when we get to chapter 10, the way that you know the rhythm is coming from your ventricles, they're going to be wide. Wide on a V. V for ventricles. Wide. So notice your QRSs here. They are narrow. They're skinny within 1 and 2 boxes. But when we get to ventricles next week, those QRSs are going to be wide, bigger than 0.12 seconds. Okay? So just moving ahead while we were on this slide. So we know that this is not coming from my sinus because there's no P waves. It's not coming from my atria because it's not, there's no P waves looking different from each other. It is coming from my ventricles, my AV junction, because we have narrow QRSs. And then next week you'll learn that it's coming from my ventricles, that there is no P wave and my QRS is wide. Which leads us with tachycardia. We already know tachycardia is a faster rate, and in this case we're talking about junction. So what is the normal rate for a junctional beats? 40 to 60 beats per minute. If it's 60 to 100 beats, it is accelerated, which means if it is more than 100 beats per minute, it is a tachycardia. Now notice the irritable spot in an AV junction has taken over as the pacemaker. Also notice, remember we talked about that SVT could be coming from your sinus, could be coming from your atria, or it could be coming from your ventricles. It's unknown. If there are no visible P waves and we are more than 100 beats per minute, it could be called an SVT. Your regularity is going to be regular, P waves inverted hidden, PR is going to be less than 0.12, QRS less than 0.12. What can cause a junctional tachycardia? Digitalis, toxicity, heart disease, stimulants. Also, your sympathetic nervous system stimulation. There's quite a few questions on your national certification about your sympathetic nervous system and your parasympathetic nervous system, your fight or flight response, or your rest and digest response. Adverse effects, we already know, decreased cardiac output. Treatment, beta blockers, calcium blockers, adenosine. Consider oxygen. Consider cardioversion if unstable. Remember, cardioversion is that shock. Why would we shock if unstable? Because we want to put that heartbeat back into rhythm. So sometimes you just got to shock it and it'll fix itself, right? Think about electrical cords or something that you plug in. What if it's a light, right? I have a lamp right here. It's not turning on, right? So maybe I'm going to shake it and then maybe it'll work. That's cardioversion. And this is what it looks like. Notice your P waves are coming after your QRS and they are inverted. So where is that impulse coming from? The lower AV. Look at all your P waves coming after. And also notice your QRSs, they are narrow. That's it. That's chapter 9. Let's see if I can remember them all. You have a PJC, premature junctional complex. You have learned about the junctional bradycardia, which is less than 40 beats per minute. Then you learned about a junctional rhythm, 40 to 60 beats per minute, and then an accelerated junctional, which is more than 60, no higher than 100 beats per minute, and your tachycardia, junctional tachycardia, which is more than 100 beats per minute. You learned that your P waves for all these rhythms, they're going to be inverted or they're going to be hidden within the QRS, or they're going to come after the QRS. You learned about the regularity and the rates being different. So these are all just those rules. So make your note card, put the name of the rhythm on the front, put your rules on the back. And also I would go ahead and make you a card now that says rhythms that affect the heart, and then write the names of those rhythms on the back of the card. Rhythms that have no effect on the heart, write the names of those rhythms on the back of the card. Okay? So here we're going to follow our rules, and I'm only going to do 2 of them with you, and you should be doing these on your own. And I can't stress enough how important it is to do these practice problems. You paid for the class. You paid for the material. The more you practice, the more better you get. It's like my phlebotomy students. The more sticks you have, the more accurate you become. The more times you practice riding a bike, the more better you become at it. Anything you do, you have to practice. So if you're just listening to these videos and you're not doing any of your practice problems, you're not helping yourself here. These practice problems are meant for you to repeat over and over and over, and eventually everything will just click and you won't have to do too much studying because you've done it so much in practice it becomes second nature. So, QRS complexes, do we have them? Yes. Regularity. How do I figure out that regularity? I'm going to count the little boxes in between each QRS. So, I'm going to stick with green today. I can tell that this is 4 little boxes plus 5 is 14. I'm going to say 15 little boxes here. All right, I see 3 here plus 5, which is 8, plus 5, which is 13, 14, 15 here. I'm going to count 5 here, which is 10, plus 3 is 13, 14, 15. 5, 10, 14, 15. 15. 15. And again, if you don't know this, this is going back to chapter 4, I believe. You're going to count all these little boxes in between. That's 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 10, 11, 12, 15, 10, 11, 12, 13. I actually got 14 on this one. And remember, your rule is if you're 1 to 2 boxes off, it is okay. Remember, nobody's heart rate is going to be exactly the same from beat to beat. So regularity, I'm pretty regular here, right? I have QRSs. What's my heart rate? If I'm regular, I can do the 6-second method. This is chapter 5. So I'm going to count each one of these QRS complexes by 10. So 10, 20, 30, 40, 50, 60, 70, 80, 90, 100. My heart rate is 100 beats per minute. Now, we know it's only going to be coming from the junction. We can't see the P waves. My QRSs are narrow. What rhythms say that the heart rate could be 100? It could be accelerated if it's between 60 and 100 beats per minute, or it could be a tachycardia if it's more than 100 beats per minute. So what do we need to do? We need to finish doing our questions. Do we have P waves? No. If we don't have P waves, can we tell what my PR interval is? No. Not applicable. What's my QRS? I see one little box. So let me erase some of these so you can see. And I can see, where does my QRS begin? It begins right here. Where does it end? Right there. One box. How many seconds is one little box? 4. What's 1 times 0.04? 0.04 seconds. Is my QR interval less than 0.12 seconds? Yes. So my heart rate is 100. I am regular. I have QRSs. I can't tell my P waves or my PR interval, but my QRS is normal. I am going to assume that this is a junctional tachycardia. Okay, next one and the last one I'm going to do with you. Do I have QRSs? Yes. What's my regularity? I'm going to look this time at the 3 boxes in between. And remember, so in this case, my spikes are at the bottom. I could use those top spikes, but my bottom spikes are more easier to look at. I can see 4 little boxes here and 1 little box here, barely, but I'm going to count it 1, and that's going to be 10. So I got 15. 5 plus 5 plus 4 plus 1 is 15. I'm going to go to the next spike. Still 1 box after and 1 box before. So I'm going to say 10, 15. That's 14. I'm going to say 15. 15. There's clearly 3 boxes there. 3 times 5 is 15. I'm going to say 15 here. Oh, I only see 2 boxes here. I got 10. I see 3.2 or 16 little boxes here. 10, 11, 12, 13, 14, 15, 10, 11, 14, 10, 11, 12, 14. Okay, so before this little problem right here where I got 10, I was regular, and after it, I was regular. But I was interrupted by a premature beat. What part of my junction of rhythms is going to be a premature beat? A, P, J, C. So I am regular but interrupted by a premature beat. I would write regular but INT. My heart rate, I'd still consider regular, so I'm going to 10, 20, I'm going to use the 6-second method, 30, 40, 50, 60, 70, 80, 90, 100. If you remember, your junctional premature beats can occur at any rate. But this is a perfect example to show that it could be a junctional tachy, or it could be an accelerated junctional. You have to go back to your rules, and I know that if it was a junctional tachy, I would not be able to see those P waves. Accelerated, I would still have trouble seeing them, but more than likely going to see them in that accelerated. So you can see your P waves here, and they are inverted. Nope, I'm sorry. They're not inverted. Sorry. Let me redo that. They start off positive and then they become negative. So everybody's going to look, they started off positive and they become negative. Okay? So this is my PJC. Alright, the rest of you, for you to do on your own, look at this one. There's no P waves that you can see. 10, 20, 30, 40, 50. So once you memorize these rules, it's easier for you to answer these questions a little quicker. If you notice, this one's definitely probably a PVC. Look at your P wave here. It came after the QRS there. So we're coming from the lower AV. Definitely irregular here, and so on. So practice, practice, practice. I cannot stress enough. The more you do it, the more better you become. Review your note cards. Stay on top of it. We've got 2 more chapters left. This is chapter 9. Chapter 10 and chapter 11, and then it's your final exam. We're there. You get a week off before we start EKG 2. Call me, text me, or call me and text me. Call my work number, leave a message, email me, or send me a message through Canvas. If you need any additional teaching assistance, I am here for you. We can do a Zoom conference and go from there. And we can even do a study group. If you have a friend in a class and you want to get with them and get with me, we can do that as well. Or we can even have a class meeting and everybody in the class can participate. Let me know what you need. I'm here for you. And don't become overwhelmed. You have everything you need. You just have to take your time and study. Remember, this is not a normal class. You actually have to put in time to understand the material. I wish you all the best of luck, and I look forward to hearing from some of you. Bye.